Well, have you or someone you know been diagnosed with ovarian cancer? Today I'm going to talk about primary surgery for ovarian cancer. That sounds good to you? Continue watching. Well, welcome back to my channel. If you're new here, I'm Dr. DuPont. I'm a board certified gynecologic oncologist, and I'm passionate about educating women on how to live longer and productive lives. And I believe that begins with great health. Well, if you or someone you know has been diagnosed with ovarian cancer, I'm going to talk about one of the many different types of surgeries that we do for ovarian cancer. Well, we now think that ovarian cancer actually starts in the fallopian tube and not the ovary, fallopian tube here. And so we have noticed over the past 10 years, the incidence of ovarian cancer is actually declining. And, it may be due to many factors. Some could be just because we're doing now removal of the complete tube or salpingectomy when women are having their tubal ligations. We used to just cut a portion of the tube. Now we take the entire tube. Well, when we talk about cancer of the ovary, we're talking about ovarian cancer, fallopian tube cancer, and then primary peritoneal cancer. So primary peritoneal cancer is the lining of the abdomen, and that is kind of treated as ovarian cancer. Sometimes we'll use these terms interchangeably. Typically, the pathologist, when you do have surgery, will let your surgeon know where is the bulk of the disease. And so that's usually how or where they felt that the cancer started. And that's kind of how we label the type of cancer. So either ovarian, fallopian tube, or primary peritoneal. But we treat them all the same. And we sometimes will use the words interchangeably, but definitely the location may be different. So let's say you had your ovaries removed many years ago, you can still get primary peritoneal cancer. It's not as common, but it can happen just because the cancer could start in that lining. And even if you didn't have your ovaries removed, you can still get cancer in that lining or the primary peritoneal. Well, ovarian cancer is one of the most deadliest cancers that I treat as a gynecologic oncologist. The American Cancer Society estimates that there'll be over 20,000 new cases this year, and over 12,000 women in the US will die from the disease this year. So it's a very important cancer that we care deeply about, and I want to just educate you today on one of the types of surgeries that we do. Now, when we're talking about ovarian cancer, there's different types of ovarian cancer. The most common is an epithelial ovarian cancer. So typically when we're saying ovarian cancer, most of the time we're talking about epithelial, where the cancer starting kind of on the outside lining of the ovary. There's also germ cell tumors of the ovary or sex cord stromal tumors. Those aren't as common as the epithelial ovarian cancer, so we don't really talk about them as much. So if you're listening something in the news media or you're hearing about ovarian cancer, most likely they're talking about the epithelial ovarian cancer because that's the most common. And 9 of 10 cases are of the epithelial type. And the most common type of epithelial ovarian cancer is high-grade serous. So that's the most common cancer or the most common subtype of ovarian cancer that I treat. Well, when we're talking about surgery, there's different kind of ways we do surgery now. We may do an open surgery, we may be doing a laparoscopic or robotic surgery. And please see my videos on those different types of surgeries. But for early stage ovarian cancer, we do what's called primary staging surgery. And so what that is for patients that are early stage, let's say stages 1 through 3B, and who have small volume disease. So what we try to do is remove the cancer, but also anywhere the cancer might have spread. So we call it a staging because we're trying to make sure we know where the cancer is. So the staging surgery is very specific. We all do it the same way. We were all taught the same way to do it. And so that's where we're going to focus on today. Now, some of the other types of surgery that you may hear or that your doctor may talk to you about may be an interval debulking surgery. So that might be, let's say your cancer is quite diffuse or it's widespread or it's outside of the pelvis. You might have chemotherapy first to shrink the cancer and then have an interval surgery later. So interval debulking just means you've had some type of treatment up front. Now we're going back to do surgery. And then often you'll have chemotherapy after the interval debulking surgery. Another term that your doctor may use that you may hear is cytoreductive surgery or tumor debulking. We say that a lot when we're talking amongst each other, but sometimes we may say, oh, we're going to do a tumor debulking. All that means is that we're going to remove the cancer that we see, or we're going to remove all of the gross disease. And we mean gross as in volume, not as in ooh. So when we're doing a cytoreductive surgery or tumor debulking, that means you have, like, say, a big pelvic mass. We're going to take that pelvic mass and remove any cancer that we can see. So those are typically called, cytoreductive surgery or tumor debulking. So those are for patients that have large volume of disease. And the other type of surgery that you may hear if you've had ovarian cancer or have someone in your family is secondary cytoreductive surgery. So a lot of times we'll have patients that, they finish their treatment, they had their chemotherapy, they had their surgery, and then they're in remission. And we follow them for several years. Well, typically, if you've had, a year or more where your cancer has not come back, and then let's say later, year 2 it comes back, or 13 months later it comes back, we may do a secondary surgery. That's often done if you have isolated disease in like one location or cancer that can be removed. So a lot of times there have been some studies that have shown if you've done very well for many years and then your cancer comes back in one location, let's say it's in the abdomen, then we'll do like a secondary debulking. We'll do a second surgery to remove the disease. Typically, again, it's disease that's localized in one area. So like, let's say it came back to the chest and you have in the lung, well, we wouldn't do a secondary debulking for that. We'll treat it differently. But typically, if it's in the abdomen, it comes back, a year or so later, then that's called a secondary debulking, just so that you understand the terminology. But today I'm going to focus on the staging surgery. I want you to know what that entails because it's a very detailed surgery. And, all of us as students or residents or trainees were taught the exact same procedure so that no matter where you go, you're having the same surgery. Now, I guess, preface this is that when you have ovarian cancer, studies have shown that if your surgery is by a gynecologic oncologist or someone who specializes in GYN cancers, you will have better outcomes and your staging surgery will be more complete. And so, a lot of times, patients will get sick and they go to the ER and maybe it's an emergency and you're not able to see a GYN oncologist because it was the middle of the night or you're in a small rural town. Well, those are kind of exceptions. If it was an emergency, you had a bowel obstruction or something where you didn't have, a GYN oncologist present, that happens and we can't avoid that. Some things in life just happen. But if you do have, let's say, a very small area on your ovary and you have very minimal disease, then we do what's called a staging surgery. So these are the components of the staging surgery. So the first, we're going to, open the abdomen, either do a open surgery or nowadays, a lot of surgeons now are doing laparoscopic surgeries, either with the robot or just a traditional laparoscope. We're going to inspect all the surfaces. We want to make sure that there's no visible tumor. And we're going to biopsy any adhesions or anything that looks abnormal or concerning. We're going to biopsy that and send it to the pathologist. If you're done having childbearing, then we'll remove your uterus and your tubes and ovaries. Now, there is something called, and I forgot to mention, fertility sparing. That's a little bit different. Usually those are patients with small volume disease who maybe haven't had their babies because they're still young. So that's fertility sparing surgery. So another term I'm going to interject. But once we've opened the abdomen, we've removed any abnormal tissue or adhesions that just look suspicious or concerning. We take biopsies of those. We'll do a hysterectomy, remove your tubes and ovaries. We'll also remove the omentum. So we'll do what's called an omentectomy, and that's removing the omentum. That's just a drape of fatty tissue that lies over the bowel. We do know that cancer likes to spread there, so we will remove that as a part of a staging surgery. And also, if you've had any of the other types of surgeries, we usually remove the omentum. I'll have patients ask me, well, if I take the omentum out, then what happens? Typically, you'll be just fine. It's just a layer of cushion. If you have to have it out, we do it for cancer purposes, but it is safe to have it removed. So after you've done the hysterectomy, the lymph node dissection, and the omentectomy, then we also do biopsies of different parts of the peritoneum. We'll take biopsies from above the bladder, below the uterus, the right side of the pelvic sidewall, the left side, and then something called pericolic gutters. We'll take both right and left. So the purpose of the staging procedure is just to sample each location or area in the abdomen to see if there's any microscopic disease. Well, we've talked about the staging procedure as it's done for ovarian cancer. I hope that was helpful. I hope it gave you some new terms to learn. And also, if you're facing this or someone in your family is facing the surgery, now you kind of know a little bit about what to expect. And I think if we know what to expect, our anxiety levels are lower and we're much more prepared. So I hope you found this helpful. If you have any questions, please put them in the comments below. And thank you for watching to the very end. And I'll see you in the next one. Bye-bye.